The next topic is the metrics of value, defining quality. So what exactly is subspecialty quality and how do we measure it? Since the 1960s, the Donabedian healthcare quality model has been used to assess healthcare systems. It involves the structures of care. Do you have a hospital? Is there an orthopedic surgeon around? The processes of care, what it is the hospital and the orthopedic surgeon does. But by far the most important measure of quality are the outcomes that the structures of care and processes of care generate. Those include the health status, the functional status, the satisfaction of your patients, the mortality rate, and of course the cost. Unfortunately, in the system of healthcare that we live in, cost is the main outcome measure that the system measures. Dollars are easy to measure, and both insurance companies, governments, and hospitals know how to measure those. And so, of course, costs are already being benchmarked. In the Michigan Blue Cross Blue Shield program, they looked at specialists and reported their costs to themselves and to the doctors who referred to them. And in orthopedics, it decreased the utilization by 13% without any special incentives or consequences. There are hosts of other measures for orthopedic surgeons that are out there. The HEDIS measurements are primarily of healthcare plans, and they measure back imaging and bone mineral density indicators. JACO measures our inpatient use, and we've all used SCIP measures and have had trouble sometimes causing harm by following the government's recommendations. NQF is a growing number of measures, but nearly all of these measures are process measures, and they don't really measure the outcome of what we do for our patients. Public ratings aren't going away, but most of us realize that a bad negative rating gets a higher priority in the system than the good ratings that our patients might give us. Finally, there's multiple private payer ratings for all the doctors in their system, but it's really hard to make much sense of them. My information on Blue Cross Blue Shield does say that I'm board certified and that I'm in sports medicine, but it doesn't say that I have a fellowship training in hip and knee replacement, and the only recognition it gives is that I have an electronic health record. Many of the payers refer to the Bridges to Excellent Clinician Rewards program, but in orthopedics, the only one that really mattered was the Spine Care Recognition program, and unfortunately, the NCQA retired the Spine Care program in August of 2012. United Health went into a little bit more detail about me. I'm proud to say that United Health has ranked me as a premium Tier 1 physician, but that doesn't really help my patients too much because it doesn't really say whether I'm Tier 1 because of my quality and cost efficiency or whether I'm just cheap and they don't have enough data to assess my quality. Cigna also has us ranked, and they say that there's not enough information to evaluate me as an orthopedic surgeon who's been in this community for 10 years and in for Texas for 20 years. So how about CMS's report card? This summer's webinar on the QRUR Quality Reporting Initiative only includes 3 diagnoses, and they're only looking at groups with over 100 providers. Most groups of specialists, it's rare to have more than 4 or 5 docs working together. The QRUR program came out of a trial in Kansas, Missouri, and Nebraska, and it only looks at the claims-based indicators that Medicare has. The good note is that it is risk-adjusted based on the patient's age, sex, Medicaid eligibility, and history of medical conditions, and they are looking at the costs of the doctors who are spent. So combining both the quality and cost is a good idea. From that data, they create this graph that demonstrates where you sit compared to your peers. The x-axis on the bottom is the percentile of doctors in your specialty, and on the left, the y-axis shows the per capita cost, what you spend per patient. But there's a problem. The fellow in red is a little bit over the average percentile in his subspecialty, but it doesn't tell you what if this guy's infection rate is the lowest of all, the total knee lasts twice as long, the ACL patients return to pro sports, or that his conversion to a total knee after a scope is greater than 10 years. Those sorts of data are not financial or claims-based. Those are outcome data. They're harder to capture, but they're more valuable to our patients and our society. Another problem with this kind of a graph is when you say physicians in your specialty, do you mean orthopedic surgeons? Well, some of us are hand surgeons, some are sports and joints and tumors. Hand doctors can frequently do tiny cases with just a knife and numbing medicine, and those cases are very inexpensive, and they may tend to be pulled down on the low end of the graph, even though they may not be as cost effective as other hand surgeons. Tumor doctors, on the other hand, have lots of imaging that they need to do, often refer their patients for chemotherapy, and put in implants that are very expensive. Sports doctors and joint doctors may fall somewhere in the middle, but what if you're a generalist who does a little bit of carpal tunnel, a little bit of sports, and some total joints? Where would you sit on that spectrum depending upon your subspecialty? A better way may be to compare surgeons based on the procedure type they do. So you can see how you might have 5 orthopedic report cards from the various payers plus 1 from Medicare with no real actionable data that doctors will believe in. No way to keep track of each other, no believable comparison between each other, no help to the insurance company, no help for our patients, and no effective change for our system of care. The problem of these independent report cards being credible was summed up in an article in Health Affairs this summer. Private insurers' assessments of individual providers' cost and quality are often hindered because the insurer has too few claims per provider. It makes the assessments unreliable, and it will lead to a loss of credibility by the providers. Pooling both the outcome results and the claim data from all payers is more likely to point toward the stars in our system that we need to emulate and the bad actors who need to be excluded. And when measuring quality, and you'd think in orthopedics it would be fairly black and white, do things that are cost-effective, evidence-based, guideline-driven, proven beneficial, and patient-centered. And don't do the other stuff, things that are uneconomical and useless, unnecessary, and unwanted. Just don't do those, and you'd have quality medicine. The problem is that it's really not black and white, but shades of gray. Most of us don't know what the costs really are for the things that we do. The evidence base for much of what orthopedic surgeons do is weak. Guidelines are few and slow to grow, and when present, they're quite permissive, frequently listing any procedure that could be beneficial instead of the ideal procedure for a certain condition. And when we talk about proven beneficial and things that make a difference, do we mean a statistically significant difference or a clinically significant difference? Patient-centered care really depends on the patient. A percent success varies with a patient's comorbidities, and those are important to take into consideration. In medicine, we spend a lot of money in the gray area, where it's easy to justify indications and where patients and doctors hope for ideal results. Acceptable use criteria do exclude certain items, but they still leave a broad path for patients and surgeons to select the care. For example, an arthroscopy in a 20-year-old with a locked knee, almost everyone would agree is cost-effective and is a wonderful thing for the patient and good medicine. Whereas arthroscopy in a 75-year-old with arthritis may not be often the right answer, but on rare occasions it may be acceptable. The vast majority of arthroscopies are in 50-year-olds with some arthritis and possibly a degenerative meniscus tear with moderate pain. The mechanical symptoms might be relieved with arthroscopy, or the symptoms may persist because of the arthritis. Measuring procedure-specific outcomes gives invaluable data on the surgeon performing the procedure. All have the same diagnosis and CPT code, and it's important to decide how to measure the quality in these groups, and the outcome is by far the best measure. Pooling the differences in functional status outcomes resulting from a surgeon's work would give an understanding of the individual surgeon's value, while pooling the results of all the surgeons doing a specific procedure could create an understanding of the specific procedure's value. The costs involved in the surgeon doing his work or in a specific procedure's use would also be put into the equation. The change in outcome and cost pooled data could be plugged into Michael Porter's formula, and surgeons could be rewarded for the value they create for society. Tangible incentives would then be created to steer all surgeons to make a bigger difference for their patients. This kind of system would steer Texas toward Kenneth Arrow's ideal insurance.